I do have one question for Samir. So, Samir, you're heavily involved in the Sentinel study. Do you do it in everybody? Is there anybody who's not a candidate, and how do you choose?
So we use it in everybody, tortuous, non-tortuous, calcified, except for the size. If the size is super large, still these days I use it, even partial protection, better than none.
Partial protection, yeah.
So in the last 6 months, we used it in everybody. And if the radial artery is not there, I don't like to stick the brachial. But I would recanalize the radial if possible, so I just stick it and go in. So everybody.
Fantastic.
So could I ask David Holmes about what you learned in South Africa about polymer valves and the idea of non-thrombogenicity?
The important part of that comes from the societal need in South Africa. South Africa, there are at most 45 cardiovascular surgeons in a country of 55 million people. There are only 170 cardiologists in a country of 55 million people. That's the first couple pieces of information. Second piece of information is that they have a huge amount of structural heart disease. Some of it is old rheumatic stuff or new rheumatic stuff. And they then are faced with having to take care of these patients when they go back to tribal areas that don't have very much support. And so there has been an initiative by Peter Zilla, who works at the same place that Christian Bernard did, to develop a new strategy to take care of those patients. So they have come up with a couple of different things. They've come up with a polymer that's similar to what has been talked about, that looks like it lasts maybe not forever, but for a really long time. It doesn't degenerate, and it doesn't develop thrombus on it. Number two, because it does not develop thrombus on it, it does not require anticoagulation. Number three, because much of their disease is bicuspid disease, and doesn't have as much calcification, in part because they're younger patients. They haven't had time to calcify. They're looking for some ways to indeed identify the best place to put this valve. And so they have a unique structure that allows it to self-center. And number four, in terms of taking care of that broad group of patients, not only in South Africa, but all of sub-Saharan Africa, they were talking about bringing this technology along so that it would be able to be used transapically, similar to what the surgeons would have known about in terms of old Tubbs dilators. That it was relatively easy to do. You didn't necessarily need all of the fancy, sophisticated equipment to do that, but you took care of a clinical problem. They are starting the trials now, as of this summer. At least that's what he told us earlier this year. The question is, would that be something that would really be an unmet clinical need in this country? And so we're then beginning to try to talk with them about that as a possibility. It's tremendously exciting. This stuff is really cool.
David, it would seem to me that a huge need for that area is rheumatic mitral. I mean, are they developing for the mitral as well?
They are.
No.
They are, and that would be obviously much more similar to the Tubbs dilator approach.
And David, am I remembering correctly that the goal of this is to be a $500 valve?
Yes.
Wow. Wow. Fantastic. Well, on that note, we'll conclude there. Thank you so much, everyone.